Ladies and gentlemen, in the United Kingdom, liver transplantation is allocated by 7 centres as shown here. UK has a centre-based allocation system where the livers are allocated to the centre rather than individual patients. In August 2006, the 3 northern centres, Newcastle, Leeds and Edinburgh, established a sharing agreement called the Northern Liver Alliance, with the purpose to give regional priority to patients on the waiting list who reach a MAL of 25, so-called top band. Even the change to transplant for these patients with livers coming from the other additional region rather than the old centre. And then it was to reduce the waiting list mortality and ensure timely transplantation of sicker patients. There are 7 NLA principles. All the patients listed with a MAL of 25 or higher, or patients that have been in the list and reaching the MAL of 25 become top band. The patients maintain their status irrespective or subsequent of the MAL changes. And the first liver available within the NLA centers or regions going to the top band patients. And if one of our patients is top band, the livers are allocated according to the highest number. And if you have a liver retrieved in your own zone and you have a top band patient, the liver gives to you. And the waiting time acts as a discriminator in case the patient have the same nerve. And in terms to ensure the equity of the sharing of that livers, there is a payback system where the first liver retrieved is given to the center that provides the liver for the top band patient. For example, there is a top band patient in Edinburgh and the liver is retrieved by Leeds, then Edinburgh owes Leeds a liver, and then the first liver retrieved in Edinburgh goes to Leeds. So the objective of this study was to review the impact of this policy from the single center perspective, with a particular emphasis to time to transplant of sicker patients, waiting list mortality, and transplant outcome. It was a prospective study for over 1.5 years, and the records were available from our unit database and also the National Transplant Database. During the study period, we elected to register 326 patients for liver transplantation in Edinburgh. 72 of those patients reached the top band criteria. 39 of them reached the MAL of 25 straightforward, and 33 of them did so after a period of listing. But if you're looking more details in my story, all the patients in the top band criteria were ranged from 25 to 49, and the patients who become top band did so after a median of 147 days. And first of all, we will have a look at the time to transplantation. The patients in the top band criteria were transplanted in average 11.5 days from listing, in comparison with the rest of the elective patients that were transplanted in over 3 months' time. And the fact that the top band patients benefit from that system is illustrated in that slide, comparing in the national system the NLA centers with the other 4 UK centers in time to transplantation of the patient listed with the MAL over of 25. And you can clearly see a significant reduction of the time to transplantation for these top band patients. During this study period, 243 elective liver transplants were performed in Edinburgh. 22% of them were within the top band criteria. And it's important to know that 44% of the livers were imported from the other additional regions in the NLA system, and only 24% were liver retrieved in our zone. And it's important to be clear that additional benefits of the wider regional sharing of the livers And because the aim of that agreement was to reduce the waiting list mortality, and for sure these patients are sick, our mortality was 22%. And if you look at this table, before the introduction of that system and after that, we can clearly see a reduction of the mortality and also the time to transplantation. And you can see that the development of the NLA system is not the only factor that contributed to those changes. And if you look at the survival from listed in the top band patients, if the top band patient hadn't received a liver, the outcome was very poor. But the intention to treat survival analysis showed a 60% survival for 1 year. But if you compare the top band patients in the post-transplant survival compared with the other patients in the elective lists, there were not significant difference between them. And again, from the national transplant analysis, comparing the NLA centers with the rest of the UK centers, in terms of transplant survival for the patients listed with a male over 25, there are no significant difference at 90 days and also 1 year. So in conclusion, ladies and gentlemen, regional priority for patients with a male over 25 allow faster access to transplantation with a good outcome. This policy has contributed to the reduction of the waiting list mortality with no negative impact in other elective patients in terms of the waiting time. Thank you very much.
Next question, please.
Mrs. transplanter, I'm a bit confused because you managed to transplant your patients within a median time of 11 days, but you still have a waiting list mortality of 18%, which I think is very high. So did you look at those patients who died on the waiting list? Were those the ones who had a male of 35 to 40, or can you give an explanation for that?
Yeah, sure. The rest of the UK and the all UK centers, the 7 centers showed you before, the mortality is around 30% in the whole country. And within the NLA centers, the mortality only was 26%. So in Edinburgh, we reduced that mortality to 22 because more of the half of the patients are listed in Edinburgh.
Might have been.
Sorry, please continue.
Might it have been an idea to even put this range high, or just allocate more according to MELD and not allow this one threshold value, but so that even within this group of MELD 25, we give priority for centimeters when donor comes from. But purely MELD-driven system in this region, is that an option for reducing waiting?
Probably because the Edinburgh have a sicker patients, our aim was to reduce and continue reduce the waiting list mortality. Probably we need more time and to analyze and compare the rest of the NLA regions as well. Thank you.
Maybe I have missed that point. What was the median MELD of those patients?
There were no median MELD. They were ranged between 25 and 49, but the majority of them were transplanted in the MELD of 25 or 26, because there were not any variations, as you see in the NLL principles, if the patients improve or worsen in the waiting list, maintain their position in the waiting list.
Yes.
So there is no, when you become top band, there's no any MELD comparable if you have 25 or 49. It's the same MELD.
Yes, that's what I understood. But the clinical situation must have led to a different MELD score. If the patient worsened and you calculate retrospectively the MELD score, it must have been different. It's not always the same, or?
Gabriel is getting all patients reaching 25 or more are given priority in the top line system.
Yes.
And irrespective of subsequent, the MELD is calculated each clinical visit or once a week for sick patients. So it's updated fairly frequently. So even if your patient gets better with the MELD dropping under 25, they still remain in the top band because they've got a chance of deteriorate.
They never
Okay.
change their
And
status
then-
respectively of the may change as said in the NLA principles.
Later on, I didn't understand it.
Okay, last word to Russ.
I just heard, I just came to think, if you were listed at less than 25, you had a stay that you couldn't get listed above 25?
Those patients that have been in the waiting list for a period of time and become sicker patients reach that criteria of the top band patients. But once that you reach that criteria, there's no any change in their status. You are in the waiting list as a priority in the NLA system.
If somebody got sicker, why wouldn't you put them to the top list?
Because
I mean, you could reduce your mortality by another 5% if you do that.
no, because we're talking about the elective registrations. If the patient is very sick, it's not in the elective list, it's in the national urgent list. And
Well,
it's a
if I would be a
different
transplant center, I wouldn't list anybody until they got to 25.
system. Sorry, say again?
I think perhaps, given time, I think we'll stop there, I'm afraid.
Well,
I think it's a very interesting topic, and I think we could go on. And I think I've heard an argument for a national allocation scheme, actually, based on MEL. But
Maybe yes.
I think we're going to come back to that as a second subject.
Center pays allocation specific.
Let's.
I would like to go on.
Thanks very much indeed. I think you did very well.